एक डिवाइस से हो जाओ, कौन दो डिवाइस से है, प्लीज एक डिवाइस से कर लो. Somebody is with two devices.
Yes.
Just close one device.
Hello. Can we start now? Okay. Very warm good afternoon to everyone. Myself, Dr. Srini Venugopal. And is it clear?
Yeah.
Your voice is echoing. Somebody has logged in by two devices.
Device two. Yes.
I think विनी ने ही दो डिवाइस से, एक फोन और लैपटॉप दोनों से ज्वाइन करा हुआ है.
Yes, ma'am. You stop one of the devices.
Vinny, you have to log in with one device, not two. Yeah. And please rename yourself also. अभी कर लेना, बाद में start the program.
Okay. So a very warm good afternoon to everyone. Myself, Dr. Sini Venugopal, and I am one of the coordinators for this wisdom series. I want to express my heartfelt gratitude to the organizers and Dr. Anju Soni ma'am for this wonderful opportunity. So without wasting any time, I, on behalf of the CCC Wisdom Series team, invite all of you for this 9th episode of the CCC Wisdom Series 24. And today we'll dive into the deep waters of infection in OB-GYN and try to fathom the turbulence it can cause in women's health and well-being. And we are going to unravel this chaos of infections, and we'll try to have some clarity and consensus. And today we have really great inspirational speakers and chairpersons for this session. First of all, I would like to welcome Dr. Anju Soni ma'am, and it's really my great privilege to do so. She needs no introduction. She has served at various societies like FOXY, ICUG in various aspects. She has been the HIV committee chairperson FOXY and governing council member ICUG, and she is the president IMS. And this is her brainchild. So she's the convener and she's instrumental in designing this wonderful wisdom series concept. So with great respect, ma'am, Anju Soni ma'am, I welcome you to this 9th episode of this wisdom series.
Anju Soni ma'am, you're muted.
Yeah, thank you very much for your kind introduction. And I'm very, very happy to be here with all of you today. Distinguished colleagues, I extend warm welcome to each of you as we convene for a pivotal webinar aimed at catalyzing the transformative change in the realm of women's health. Today's gathering represents a unique opportunity for us to collectively delve into the nuanced landscape of obstetrics and gynecological infection, guided by esteemed experts, fueled by shared commitment to excellence. Our program features two illustrious keynote speakers, each renowned for their unparalleled contribution to the field. First keynote would be delivered by Professor Geeta Bhalsekar, a luminary in women's health, the editor emeritus of Jogi. Professor Bhalsekar addresses titled Maternal Mortality Due to Infection, Indian Scenario, which is so very much important for all of us to know so that we can manage them and we can overcome the hurdles we are having. Promises to shed light on the sobering realities of maternal mortality and chart a course towards effective mitigation strategies within the Indian context. Equally compelling is the keynote second, presented by Professor Niranjan Chauhan, Joint Treasurer FOXY, with his presentation entitled Past, Present and Future of OBGYN Infections. Professor Chauhan will lead us through a comprehensive examination of historical evaluation, future trajectory, and of obstetrics and gynecological infections, offering invaluable insights for our collective journey forwards, guiding our deliberations with expertise and finesse is Dr. Sampath Kumari, Professor Sampath Kumari, and Dr. Preeti Singh. Dr. Sampath Kumari, Vice President, Foxy 2023. Their leadership ensures that our discussions are grounded in evidence-based practices enriched by diverse perspectives, setting the stage for actionable outcomes and meaningful impact. Behind the scene, the coordination effort of Dr. Sini Gopal, Professor Kanchan Prasad, and Dr. Shubha Chetia have been instrumental in shaping the contours of this webinar, and their meticulous planning and unwavering dedication have laid the foundation of dynamic exchange of knowledge and ideas, poised to empower our community with tools necessary to confront obstetric and gynecological infections with confidence and competence. Over to you, Dr. Vinny, to invite the chairpersons.
Dr. Kanchan will invite the chairpersons. Dr. Kanchan.
Yes, ma'am. Thank you so much, ma'am. So now we will start with the session of keynote address. And to chair the session, we have very dynamic and learned lady of Foxy, Professor Preeti Kumar, madam. Okay, we all know her very well, and we meet her at each and every conferences and each and every almost all the activities of Foxy. So Preeti Kumar, ma'am, is chairperson, maternal and perinatal committee support, chairperson Safe Motherhood Committee Foxy during 2020 to 23, committee member of MFM Committee AFOG during 2024 to 2022 to 24, Joint Secretary of India Justices Chapter 24 to 26. And ma'am is currently Professor and Head of Department of OBGYN by Narayana Institute of Medical Sciences, Kanpur. And ma'am is conferred with many prestigious awards, including Foxy Late S.N. Malhotra Appreciation Award, and a recipient of Sane Ahan Shining Star Award, Women Healthcare Award. So the list is endless. And ma'am has 50 publications and in different index journal and edited many books. So we welcome you, ma'am, and I request you to kindly introduce our speaker.
Thank you so much, Kanchan. Before I introduce the learned speaker, Dr. Geeta, I would like to thank Dr. Anju Soni. I think very good friend of mine, a very charming lady, and I wish her all the good luck for whatever endeavor she does. And I really find her very dynamic, and she has also taken over as the president of IMS. That's also very prestigious post. So thank you so much, Dr. Anju. It is always pleasure and honor to share the dais with learned speakers, Dr. Geeta and Dr. Niranjan. And I'm also thankful to all the three coordinators, very humble and very, efficient, I must say, because I'm constantly getting messages from someone or the other. So thank you, Sini, thank you, Shubha, and thank you, charming Kanchan, for your kind words and introduction. So I think this is a wonderful series. I have been observing it for a long period of time, the Wisdom series. And today's topic is infection in OBGYN. And I'm very happy that you have selected very eminent speakers, Dr. Geeta and Dr. Niranjan, and they will definitely do justice to this topic. So today's topic is, I think the introduction has already been done by Dr. Anju. And Dr. Geeta, we all know her for her academic, the content she speaks on any topic. I really always like to join whenever she's speaking on any of the dais. And she's going to speak on maternal mortality due to infection, the Indian scenario, which is very, very important because infections are very important causes of maternal mortality after hemorrhage and hypertensive disorders in pregnancy. So the first talk would be on maternal mortality due to infections. Over to you, Dr. Geeta. Dr. Anju, do you want me to read the CV of Dr. Geeta again? I would really like to, just let me. Dr.
No, ma'am, it's okay. I was there in my first slide.
Okay. Thank you so much. Okay, bye-bye. Thank you. Go ahead.
Yeah. I must thank Dr. Anju Soni for this, wonderful opportunity. And we have to thank COVID because it gave us a different perspective, which was not there before that. And I'm really thankful that we came across these webinars. It's a very good way of learning. Actually, otherwise, I would have never known these youngsters, Dr. Kanchan Prasad, Dr. Shubha Sethi. I would have never met them or I would have never known them in my entire life. Even if I would have come to Jaipur, I would have just met them once or twice. I wouldn't remember them. So this gives me a wonderful opportunity to interact with colleagues. I am very grateful for the topic today, that is a maternal mortality due to infections, the Indian scenario. This is something which is very, very close to my heart. All of us, all obstetricians are always busy and we are working. So what are we working towards? We are working towards giving a healthy mother and a healthy child. That means we are working towards reducing maternal mortality, isn't it? And maternal mortality has been a problem in our country right from Shah Jahan's days. It's not something that is there yesterday, today, last year, or 10 years or 20 years. It is there from centuries together. And things are changing, but they are actually not changing. The poor woman is at the receiving end at childbirth, and whether there is a proper obstetricians, whether there are midwife dies, or whatever the scenario, the woman loses her life during the childbirth. So this is the worst scenario. And when faced with this, it gives tremendous stress to the obstetrician. I am a Foxy representative to the district inquiry committee into the maternal mortality in Mumbai and Maharashtra. So that is what has led me into thinking. And all the cases wherever there is maternal mortality, they are presented. The concerned obstetrician and the other specialist doctors, they come in front of a group or a panel of people and they present their case, and then we discuss, and then we have to give our opinion. Where there are various classifications. WHO has given us a classification, whether it is preventable, whether it is non-preventable, at what level is the gap, level 1, level 2, level 3, where is the gap. So we have to give, all of us are there. There is a physician, there is a surgeon, there are 3 gynecologists, then there are a pathologist, there is a forensic person, there is a staff nurse, there is an anesthetist. This is a very big panel, and it inquires into the maternal mortality. So this is what is my experience with the cases of maternal mortality. And if you see the maternal mortality trend in India, I can talk to you right from Shah Jahan days, but what we have here is from 1990 to onwards. So if you see, does any of the people know what is the maternal mortality in India today? Does any of you know? Most of us are not even aware of where do we stand, unless we learn to sort of look at ourselves, look at our practices, and unless we learn to regulate ourselves, whatever happened in ART will soon happen to other practices of obstetrics. So we have to learn to regulate ourselves, and maternal mortality is one such thing. So I request that a group of gynecologists should get together and discuss your mortality, and not only your mortality, even your near miss cases. They have to be.
meeting हो रही है तो सोने दो उसको. तब से
There is some disturbance. I would request everyone to mute themselves.
So if we see the maternal mortality trend in India from 437 in 1990, like when I joined MBBS, it was like 1990. When I finished, rather, it was 437. From there, we have come in Mumbai and Maharashtra, we are 40 and 47. So it is that low. Actually, Maharashtra is doing even better than India as a country, and Mumbai is same as that of India. So the maternal mortality has gone down. That means if adequate measures were taken in 1990, even at that time, our maternal mortality could have been down. So there is something that we have not been doing all these years, which has started reducing the maternal mortality. Poor women have lost their lives for no fault of theirs. So we have to form rules, regulations, our restrictions, and self-regulate. Our bodies have to self-regulate and investigate our own maternal mortalities, and not only maternal mortalities, even near miss, so that our maternal mortality is kept least. Now, there are 7 states which have very high maternal mortality. You can see that which is colored in red and orange. They are very high. That is 130 or more maternal deaths per 1 lakh live births, and high is 100 to 130 maternal deaths. Now, unfortunately, we are one country. Therefore, wherever a mortality is happening, all of us have to equally take responsibility for it and try to reduce that. And it has actually, even in those places, it has improved from 113 in 2016-18 to 103 in 2017-19. But in West Bengal, Haryana, Uttarakhand and Chhattisgarh, the ratio has actually worsened. Post-COVID, the maternal mortality ratio has worsened. Now, if we see the maternal mortality rate in India, according to the SDG goals, reducing the global maternal mortality rate to less than 70 per 100,000 births, with no country having a maternal mortality of more than twice the global average. This is what is the, by 2030, SDG goals have said that we should be not having more than twice the maternal mortality for global average. The National Health Policy 2017 said the target for maternal mortality is 100 per 100,000 live births by 2020. So if we see from 2014 to 16, it was 130, and 2017-19, we have come down to 103. Karnataka and Haryana, in addition, have achieved the National Health Policy 2017 target. The states which have achieved are Kerala, which is only 30, Maharashtra, which is 38, and Telangana, which is 56, Tamil Nadu, which is 58, Andhra Pradesh, which is 58, Jharkhand 61, and Gujarat 70. These states have already achieved the SDG target. But the states with very high maternal mortality rate like Assam 205, Uttar Pradesh 167, Madhya Pradesh 163, Chhattisgarh 160, Rajasthan 141, Odisha 136, Bihar 130. Here each and every obstetrician has to take up the cause of maternal mortality. Like Dr. Anju Soni, like Dr. Preeti Kumar, each of us has to be talking about maternal mortality everywhere. Only then we will be able to get anywhere near the SDG 3 goals. The causes of death and morbidity worldwide, if we see, of course, as Dr. Preeti Kumar has said, severe bleeding and eclampsia, they form a very important part of the mortality, but nonetheless, infection also forms a 15% part of the maternal mortality. We have a lot of indirect causes like anemia, malaria, heart disease, which are endemic to many of these places in India, and they contribute to the maternal mortality. So the puerperal sepsis is the leading cause of maternal death in the postpartum period. Now, puerperal sepsis, anywhere between 11 to 15%, they form the cause of the maternal mortality. This is WHO 2014, but it can be easily managed by maintaining hygiene and hand washing and following strict infection prevention practices before handling the mother, reducing frequent PV examinations during labor, early identification and judicious use of antibiotics for mothers showing signs of infection. Well, from 1992, when I joined obstetrics and gynecology, I'm reading this. And today it is very sad that 30 years later, we are still talking about the same things. And none of us have majorly changed our practices regarding hygiene, hand washing, infection prevention practices, reducing PV examination, and early identification and judicious use of antibiotics. Now, pregnancy-related deaths, if we see, there can be a maternal death or it could be incidental, that is non-maternal death, where it can be because of external causes, accidents, or coincidental. Now, pregnancy-related maternal death can be direct, it can be indirect, or it can be unknown. In the direct one, abortions, miscarriage, ectopic pregnancies. Please don't underestimate abortions. Patients can bleed due to abortions, miscarriage, ectopic pregnancy, hypertensive disorders, preeclampsia, eclampsia, with our patients getting pregnant in the later ages of life. It's not uncommon to have 35 and 36-year-old primigravida. Many of them are chronic hypertensive, gestational diabetics. So these lead to preeclampsia and eclampsia. Obstetric hemorrhage, antepartum, postpartum hemorrhage, infection is puerperal sepsis, other obstetric complications, unanticipated complications like adverse effects, medical, surgical problems, non-obstetric like cardiac disease, infections which are not directly because of pregnancy, tuberculosis. Many of our obstetricians, we don't screen patients for tuberculosis. If we have any patient who has chronic cough with sputum, Please don't hesitate to do a simple X-ray chest after 16 weeks. We are so petrified of doing an X-ray chest that we do not diagnose the tuberculosis and we allow the patient to die of miliary tuberculosis, but we don't do an X-ray chest. So after 16 weeks with the abdominal shield, it's quite safe to do an X-ray chest. We can do complete blood count. We can do sputum for AFB. We are all, though we are obstetricians, we have also done MBBS. We should know how to screen our patient for tuberculosis. And in a place like Mumbai, I find tuberculosis, we are losing at least 3 to 4 patients every month from tuberculosis and miliary tuberculosis, that too. Please don't hesitate to screen. You screen patients for HIV, you screen patients for HBsAg, you screen patients for anemia. Then why don't you screen patients for tuberculosis? So we have to remember that we are MBBS first. And we need to look at patient as a whole and screen them for tuberculosis. Tuberculosis is a leading cause of maternal mortality in crowded places like Mumbai. So we have to screen patients for tuberculosis as well. Now, we all know that pregnancy causes a lot of changes in the system. The cardiovascular system of the mother undergoes changes. There is a reduction in systemic vascular resistance, reduction in blood pressure, increased blood volume, increase heart rate, increase cardiac output. Respiratory is reduced pulmonary vascular resistance and plasma colloid pressure, reduced residual volume, reduced functional residual capacity, increased tidal volume, increased minute ventilation. Renal is increased plasma blood flow and glomerular filtration rate is increased. So it is a pregnancy is a procoagulation state. So factors 1, 2, 7, 8, 9 are all increased. Protein S is increased and plasminogen activated inhibitors are increased. Similarly, for sepsis, what we need is the same thing. So whatever are the signs and symptoms of sepsis are very much similar to that of the pregnancy. That is why we miss sepsis in the early period. If you see, if you compare on both sides what is there, whatever the signs and symptoms of pregnancy and the signs and symptoms of sepsis are the same. There will be a cumulative effect, changes in the cardiovascular system, changes in the respiratory system, where the patient gets susceptible to pulmonary edema. There is rapid decrease in oxygenation, adult respiratory distress syndrome, decreased ability to compensate for metabolic acidosis, acute kidney injury. All this put together, even small amount of infection, these patients are not able to fight against and they tend to lose their lives. So pregnancy is very much prone to all the infections. So we as obstetricians, we may not be medical people, but we have to screen patients. Or if you are not confident, please send your medical colleagues. But don't let pregnant patients die of things like miliary tuberculosis. So there are all these are interlinked causes. Like direct cause is bleeding, which leads to infection, anemia, uterine rupture from local oxytocin, retained placenta. Indirect causes are convulsions, HIV, hepatitis. All these reduce the patient's ability to fight infection further. Urinary tract infections, socio-cultural resistance, a preference for the home birth, or local oxytocin intake, belief in herb spirituality, delays, deciding to use the healthcare facility, delay effecting emergency referral, transport, cost, distance to facility. All these put together cause maternal and neonatal mortality. And if not mortality, it leads to a lot of morbidity. Mortality is only at the tip of the iceberg. And below that, we have to face a lot of morbidity. There is lack of support to the mothers, health illiteracy. She's newly married. Within a month or two of marriage, she misses her period. The entire 9 months she takes out in misery. She has no support either from the mother's side or from the in-laws side, risky economic activities, and there are a lot of self-medications nowadays, smoking, alcohol, all this put together, socio-economic issues makes the woman completely prone to sepsis. And if any infection occurs little bit, it gets blown and she's not able to fight it. What are the predisposing factors for the puerperal sepsis? Antepartum, the beginning of infection begins right in antepartum. Malnutrition, anemia, preterm labor, early rupture, PPROM, precipitate delivery, immunocompromised status like diabetes, AIDS, obesity. It's not uncommon to find 120, 130 kilo patients nowadays. Organisms of vaginal flora, intrapartum, repeated vaginal examination, dehydration during labor, ketoacidosis during labor, traumatic vaginal delivery, antepartum hemorrhage of PPH, retained bits of placental tissues or membranes, prolonged labor, obstructed labor, cesarean or instrumental delivery. All these are predisposing factors to puerperal sepsis. Now, there are organisms of the normal vaginal flora. Everything nowadays has come back to probiotics and how we manage the gut and the vaginal flora. Vaginal flora in the late pregnancy and at the onset of labor, it consists of the following organisms. Primarily, it's the Dodderlin's bacillus. There are few Candida albicans, Staphylococcus aureus, Streptococcus, E. coli, Bacteroides group, and Clostridium welshi. These organisms remain dormant and are harmless during normal delivery conducted in the aseptic condition. But because of the devitalization of tissues like extensive perineal tear, if there is extension of episiotomy, traumatic delivery, because of the devitalization of the tissues, the pathogenic organisms, they gain foothold either in the traumatized tissues of the uterovaginal canal or in the raw decidua left behind or in the blood clots, especially at the placental site. And from there, they go on multiplying and cause infection in the patients. The Dodderlin's bacillus, these are the good bacilli. They have a beneficial effect by inhibiting the growth, adhesion, and spread of the other microorganisms. So during the entire antenatal period, we must look at good gut practices or good, heating habits so that the Dodderlin's bacilli grow in the vagina, and this prevents patient from sepsis. So if we see the causal organisms, it can be aerobic bacteria, it can be anaerobic bacteria, or it can be the others. So the endogenous, where the organisms are present in the genital tract before delivery, like the Streptococcus. Autogenous, where organisms are present elsewhere, like the skin, throat. They migrate to the genital organs by bloodstream or by patient herself, like E. coli, which comes from the gut and the perineal area and then enters the vagina. Exogenous, where infection is contacted from sources outside the patient, like from hospital, beta hemolytic streptococcus, staphylococcus. These are from the attendant or the doctor who is delivering or the people who are attending to the patient. From them, you get this exogenous infection. If you see the pathogenesis, the endometrium, which is in the placental implantation site, cervix lacerated wound, vaginal wound, perineal lacerated wound, they are the favorable sites for bacterial growth and multiplication. These devitalized tissues, blood clots, foreign body, which could be, sometimes forgotten cotton swabs, retained mops, surgical trauma, they favor the polymicrobial growth, proliferation, and spread of infection. This ultimately leads to metritis, any itis. It could be endometritis, parametritis, cellulitis. Puerperal sepsis is commonly due to endometritis, endomyometritis, and endoparametritis, or a combination of this, which is called as a pelvic cellulitis. If there is widespread infection, you can even have the pelvic vein thrombosis in these cases. So septicemia can lead to streptococcal pharyngitis, it can lead to rheumatic fever, it can lead to rheumatic heart disease, scarlet fever, erysipelas, cellulitis, necrotizing fasciitis, and streptococcal toxic shock syndrome. These are all the results of the septicemia which the patients get during the delivery that we do to her. So this is the extrauterine or the intrauterine infection and inflammation which causes the SIRS, sepsis or severe sepsis, and eventually pushes the patient to shock. What is a global scenario? Globally, direct obstetric maternal infections are the third most common cause of maternal mortality, representing anywhere between 10 and 12 and 15 maternal deaths. Infection is also a very important cause of indirect non-obstetric maternal death, like malaria, HIV, influenza-like illness, even COVID, because nowadays COVID is presenting as multi-organ failure. among the others. Globally in 2017, there were approximately 5.7 million women presenting with maternal disorders complicated with sepsis. A majority of these women come out of the infection. They get treated. We lose only a few women, like the tip of the iceberg, but there are a lot of women behind that who have morbidity or who have suffered because of this maternal infection. Now, if we see in India here, 11.7, where you can see this is the infection all over India. In Maharashtra, Tamil Nadu and Kerala, it is around 8.2%. In Bihar, Jharkhand and Uttar Pradesh, it is 9.6%. So roughly all over India, infections are somewhere between 10 and 12% among the causes of the maternal mortality. Now, if you see in this chart, the primary cause is pregnancy-related infections, like it could be PPROM, repeated PV infections, fever, it could be breast engorgement and breast abscesses, metritis with pelvic cellulitis. Then you can see septic abortion. It is still happening in India. Septic abortions are still a very important cause of maternal mortality. You can see tuberculosis, which is circled here. About 10 patients, that is 4.7%. We obstetricians are missing tuberculosis. We do not put stethoscope. Patients remain in ward for 5 days, 10 days, and then they are found to have mitral stenosis. We do not auscultate the fetal, we do not auscultate the mother's heart, and we do not auscultate the lung. Air entry we do not see. Tuberculosis is one of the causes of maternal mortality among the infections. Malaria, dengue, hemorrhagic fever, typhoid, herpes, HIV, hospital acquired infections. These are the other causes. Now here, if you see sepsis, PIH, they are very, very significant. Here again, I like to point out that tuberculosis and the other respiratory disease infections are a very important cause of maternal deaths. Now, what are the characteristics of maternal infection? If you can management by the severity group, you will see that the sources of infection could be urinary tract. It is essential to screen patients with urine culture periodically during pregnancy to prevent urinary tract infection, endometritis, chorioamnionitis, skin and soft tissue, respiratory, abortion-related, bloodstream peritonitis or abdominal cavity infection, then gastrointestinal, breast, CNS, and the other. This is how the infection is from more severe infection to the less severe infection in terms of leading to maternal mortality. Now, World Health Assembly sepsis resolution, the true burden of maternal sepsis and its complications is very, very uncertain. Like I said, a lot of maternal morbidity because of sepsis is swept under the carpet and is hardly discussed and is hardly, it comes to the notice. Given the absence of standard definition, identification criteria, measurement tools, I may feel that patient is in sepsis. Somebody else may not agree with me. So there are variations in populations and sources of infection studied. Therefore, there is so much uncertainty and we don't know what is the true burden of maternal sepsis. It is globally recognized that prevention, early diagnosis, and prompt management of infection and sepsis, they are key factors for reducing the morbidity and mortality as reflected in 2017 World Health Assembly sepsis resolution. It was in 2017 that WHO took notice that sepsis is increasing and is becoming one of the leading cause of death. Now, there is acute sepsis. There is a GLOSS campaign, which this is the pamphlet which is there at WHO. You can find it at the WHO website, wherein they are trying to educate the obstetricians, like what are the signs. That could be fever, or it could be even hypothermia. Patients के हाथ पैर एकदम ठंडे पड़ जाते हैं, fast heart rate, low blood pressure, respiratory distress, jaundice, decreased urination, altered mental status. If any of these, we have to act very fast. And who are at risk? Any woman who is pregnant, who has had a miscarriage or an abortion, or who has given birth, they are at risk of developing maternal sepsis. So what is the Indian government doing? Indian government is very, very seriously looking at improving our maternal mortality rate. So like every district has got a committee which looks into the maternal deaths in that particular district. If there is proper reporting, I don't know how many districts are taking it very seriously, but the government wants it to be done very seriously. And if we as obstetricians don't take it seriously, then we will find soon legislations and we will have to follow the laws. So there is, the Indian government has brought about comprehensive abortion care services, the provision of medications, equipment, information and communication, among other things, training of healthcare professionals and services for comprehensive abortion care. There should not be a single septic abortion or a single abortion that is done, without a proper gynecologist. So they are training more and more people for abortion care services. Then there is midwifery program. The goal of the midwifery program is to develop a cadre of the practitioners, nurse practitioners, who are competent in accordance with the international, the Confederation of Midwives competencies, and to provide compassionate services for the women-centered maternal and newborn care. Then there are delivery points. Nation has more than 25,000 delivery points with improved infrastructure tools and educated staff to provide the RMNCH plus N services. Then there is Janani Surakshana Yojana 2005. It is a demand promotion and conditional cash transfer program. It is cash goes directly into the patient's accounts. It intends to lower the maternal and infant mortality by encouraging institutional delivery among the expectant mothers. Then there is Janani Shishu Suraksha Karyakram 2011. It gives pregnant women and unwell babies access to free transportation. Remember, pregnant women have to get free transportation to the hospital, cesarean deliveries, diagnostics, medications, other consumables, diet, blood in public health facilities in an effort to minimize the out-of-pocket cost for these individuals. Then Pradhan Mantri Surakshit Matritva Abhiyan, PMSMA 2016. On the 9th day of every month, Matritva Abhiyan offers pregnant women a set day of quality antenatal care that is guaranteed to be free of charge. Foxy had also volunteered to do this in 2016, 17 and 18 before the COVID. On the 9th of every month, we used to offer pregnant women free antenatal care and consultation. Then there is Lakshya 2017. Lakshya wants to raise the standard of care provided to expectant mothers and their babies in operating rooms and labor rooms so that they can have a healthy delivery and early postpartum period. Then there is Surakshit Matritva Ashwasan, that is Suman 2019, aspires to provide every mother and newborn who visits a public health institution guaranteed, dignified, and high quality healthcare at no cost. Then there is functionalization of FRUs, that is first referral unit, ensures that the first referral unit are functional by providing staff, blood storage facility, and referral connection. Then setting up of maternal and child health, MCH, wings in facilities with a large caseload to enhance the standard of care given to mothers and children. Maternal death surveillance review. The goal is to enhance the standard of obstetric treatment and take remedial action at proper levels. Then there is monthly village health, sanitization and nutrition day, community outreach initiative for the provision of nutrition-based maternal and child care. Then there is regular effort carried out for encouraging institutional delivery, reducing home deliveries, encouraging institutional deliveries, early registration at ANC, regular follow-up of ANC, nutrition. Government is putting a lot of effort on the maternal and child nutrition and care during pregnancy. Then pregnant women are given the MCP cards and safe motherhood booklets to help them learn about the institutional births, benefit programs, warning indications of pregnancy, food, and rest. So you can see every year our government is instituting new and new program, and government is very, very serious and is following up on the maternal death surveillance review. So how can we obstetricians prevent? First of all, we have to self-regulate ourselves. In case of any maternal death or near miss, a group of people or an organization, if they are attached, they can discuss these particular cases, minute it, and sort of keep it somewhere, so that in case there's an inquiry, we can say, well, we discussed this and this was what was the outcome of the discussion. Diagnosis and treatment and screening of urinary tract infections, very, very important. Diagnosis and treatment of anemia and malnutrition, diagnosis and treatment of diabetes mellitus, because diabetes also is an immunocompromised state, assessment of risk factors for fetopelvic disproportion, diagnosis and treatment of pre-existing sexually transmitted infections like gonorrhea, chlamydia, diagnosis and treatment of other vaginal infection, and proper management of prolonged rupture of membranes if it is more than 12 hours. So we all know that among the pregnancy complication, death is at the topmost. There can be pregnancy loss, there can be preterm birth, gestational diabetes, eclampsia, fetal and neonatal complication, IUGR, stillbirth, neonatal death, microcephaly, hearing loss. The morbidity is too much. Neurodevelopment disorders, ocular abnormalities, motor disorders, long-term health issues like cognitive impairment, compromised immune system, diabetes, hyperglycemia, obesity, COPDs, cancer, heart disease, aging. It can lead to all of these because of a not properly attended and managed pregnancy and labor. So we have to issue, FOGSI has to issue statements on maternal sepsis. We have to recognize the need to foster new thinking and to catalyze greater action to address this important cause of maternal mortality. So there are other incidental infections like rheumatic heart disease, infective hepatitis, cholangitis, cholecystitis, tuberculosis, malaria, dengue, leptospirosis, typhoid, H1N1, COVID, influenza, HIV, AIDS, diabetes. We have to be proficient in screening for all these diseases. 78% of our maternal death resulting from sepsis have come to the hospital in a moribund state, irreversible shock, and they all die within 48 hours after admission. Why does this happen? Why don't women come to hospital on time? Early recognition and timely treatment is the key to ensuring a favorable outcome. So not only we have to work very hard, we have to educate our other specialists like medical, surgical, that our women are young, and if they are sick, they have to get a priority while waiting in their long OPD queue to be seen. They have to be seen, given a priority to be seen, because if they are treated at the appropriate time, they can survive. So there is a new global target for reducing maternal deaths. We aim for less than 70 deaths for every 100,000 live births by 2030. This is the sustainable goal of the 3.1, and it from 2016 where we have to go to less than 70. So thank you for a patient hearing, and I hope I have sensitized you enough on this issue.
Enough. Very nice presentation, Dr. Geeta. I think you have emphasized on a few very important points. One is the 7 states in India where we need to focus. And I know I belong to UP, and UP is one of them, because we have MMR of 167, which is pretty high, but still sepsis comes third in UP after this hemorrhage, hypertensive disorders, and sepsis. So the main issue, what I think, is anemia. If I introspect, because we go to these facilities, anemia and nutrition, these are the key factors, because we don't have those kind of blood storage units or even blood transfusion facilities there, and most of the pregnant women land up with anemia. So I think that's the biggest challenge that go hand in hand with sepsis. So we need to work on that. And you rightly, commented on abortions, because that's really still needs a lot of focus. Recently, we got a patient, 2nd trimester abortion. The entire wall of the uterus was totally gone, and patient came in septicemia from one of the remote areas, Hardoi, to our, center. So these kind of cases we are still seeing. And then rightly mentioned about the tuberculosis, which is very rampant and very common problem, especially if I talk in the north. Again, tuberculosis is one of the important causes, not only for the infection, but also for the infertility. So tuberculosis is somewhere we need to focus more, and we have programs. And you rightly mentioned about the several programs which the government is doing. And we should not forget that the Manyata is also one of the program which talks about the quality care in the maternal health.
That Lakshya
And
is that Manyata only actually.
Lakshya is something like Lakshya
Like
Manyata. has
Manyata.
been- No, Lakshya is,
Manyata is Foxy, Lakshya is from the government.
yeah, Manyata is Foxy because we don't have Lakshya Manyata here. In Maharashtra, we have Lakshya Manyata, so that is endorsed by
Yeah.
So Manyata also we are talking a
that
lot
will
about the
show us
infection
what all
prevention and all.
changes.
So
Yes,
can
yes.
somebody?
Even the lanyards, the different
No,
colors.
I
and
think
it's showing.
प्रिंट लेके ही आया था
Yeah.
कौन भैया बात कर रहे हैं? Ranjit, can you check who is talking?
Certificates we like.
Certificates
I'll give you 3 options. I'll get no. 3 options you gave, but one will be delegate, one will be faculty, one will be workshop.
Could everyone please mute themselves? There is
I am also muted. So I think Dr. Geeta, a lot of insight you have given on the topic, and we really need to work hard. Foxy also definitely is working, but definitely more and more sensitization also on the infection and the sepsis part. So thank you so much. I'll request conveners to put a comment that whosoever wants to ask any question, they can be taken up later, because we have the second faculty here, none other than Dr. Niranjan, a very good friend, and he's working as a joint treasurer now in Foxy. We know him, a very good academician and very busy practitioner. He's from Sion, he's unit head, and we have seen him in several posts. He has more than 70 publications, and I know him very well. So Niranjan is going to talk on very important subject, that is infections in OBGYN past, present, and future. Dr. Geeta has given a lot of insight about the infections, but let us hear from Dr. Niranjan what he has to say about past, present, and future of OBGYN infections.
Yeah. Thank you. Thank you so much. Hello.
And the important thing is the organizing secretary of the, the coming upcoming AICOG conference. So
Thank
Niranjan,
you,
over to you. Yeah, over to you. Please go ahead.
Yeah. Thank you, Preeti. Right now, we just finished one meeting of AICUG. So I was in midst of that. So that's the reason I have sent the recordings, which the organizers are aware of it. And I would request them to play the recording.
Okay.
I have tried to cover all the points of past, present, and future of infections in obstetric gynec.
Yes, Vipin, you can. Yes,
Right.
Vipin, you can start.
Start
Vipin?
the video.
Yes,
Start
ma'am.
the
Yes,
video.
ma'am.
please.
Starting the video. Yes, ma'am.
So we can have the final comments later with Dr. Niranjan. So please
Sure.
start
So
the
I would like
video.
to thank Anju Soni and her team and the chair, Dr. Preeti Kumar, and all the wonderful ladies who are there. I can see Kanchan Prasad, I can see Shubha Sethia, Dr. Srini, Venugopal, and of course, there are so many members and faculties who are present today. So let's hear my recording, and thank you for your cooperation, and I'll join you after the lecture. Thank you.
Okay, Niranjan.
Vipin, you can start it.
Yes, ma'am.
There are more people.
Vipin, it's not audible. Vipin, it's not audible.
Okay, we'll
There was no
Yes, ma'am.
sound.
Yes, ma'am. Again, try to.
फिर से start कर दो.
I will share, ma'am, from my side. Yes.
Yeah, please.
सिनी कोई questions तो नहीं है ना कहीं लिख पे? If there are any questions?
नहीं मैम, क्वेश्चंस कहीं कोई चैट बॉक्स में नहीं है कहीं।
Okay, Kanchan. ऑडियो नहीं सुनाई दे रहा है.
Let me, Vipin, let me check if I can play, please. 1 second, just give me 1 second.
Good evening, everyone. Today I will be talking on past, present, and future in obstetric and gynec infections. Welcome to CCC Wisdom Series, episode 9 on 27th of March 2024. My overview of the lecture will be on infections, historical aspects, septic abortion, home deliveries,
Ma'am, audio is coming in video. Anju ma'am, you are on mute.
अभी तो आ रहा था, बंद क्यों हो गया?
Audio is coming, na ma'am. That's why I'm
हाँ
confirming.
हाँ, ऑडियो वीडियो दोनों आ रहा था.
Okay, okay.
आ रहा था Vipin. It was
Yes, ma'am.
going great.
Okay, ma'am. Continue.
specific mentioning of HIV, hepatitis B, C, and syphilis, surgical site infections, puerperal sepsis, and take-home messages. Infections in obstetric and gynec, we come in our day-to-day practice every day, and we learn from the issues which we come across. So we can have pregnancy-related infections and non-pregnancy related infections, and infections which are incidental to pregnancy. So we'll go one by one, but major issues which are to be discussed is just been mentioned into the overview. So let's back and go to the history, and let's find out from where this infections were started and from where antibacterial and antibiotics were introduced, including ancient history. Our Sushruta, father of surgery, he is a pioneer, and more than 5,000 years it has been mentioned in the scriptures of our ancient history, the contributions of this great man. Well, this was started during the 6th century, and he is known as the father of Indian medicine and father of plastic surgery. He lived in Kashi, which is popularly known as Banaras or Varanasi in the northern part of India, and he has, to his credit, pioneering operations techniques which has been mentioned in the Susruta Samhita or the compendium of Susruta. This is the main source of knowledge which he has given to our ancient India. These are the palm leaves which has been stored in the Los Angeles County Museum of Art, and this text dates back to the 12th and 13th century, while the art is dated to 18th and 19th century. You can see on the left hand side the ancient scriptures which are mentioned, and on the right hand side the instruments which were called different names. The instrument in Indian language is yantra. So you have different types of yantra, and you can see that there is a forceps, there is a scissor, there are also cutting knives, and there is also a forceps which you can see. Let's go back to the history of LSCS. History of LSCS is a very important history taught in our obstetric and gynecology, and it's basically the Lex Regia, which is the Lex Caesara. It was a law which was passed in 715-673 BC. Here the law suggested that no baby would be dying in the mother's womb if the mother is dying or would to be dead. So the mother's womb, her abdomen had to be cut open, and then the baby had to come out, and then this mother can be buried. But it was forbidden that the mother's burial cannot occur with a baby inside. So this is what is also mentioned in 1598 of Jacques Guillemeau book, and this was a book of midwifery, and later the term section was replaced by operation. Now this picture you see is an old picture where it is purportedly mentioned that the birth of Julius Caesar occurred during this time, but it is a doubtful situation, and a live infant has been surgically removed from a dead woman. This is also mentioned by Suetonius in the Lives of the 12 Caesars in 1506. How can we forget the contribution of Semmelweis? He was an Hungarian doctor, and in the year 1846 to be precise, he started working in a general hospital in Vienna in a maternity setup. He wanted to figure out why so many women in the maternity wards were dying from puerperal fever, which was commonly known as the childbed fever. So in this hospital, he had two wards. One was the ward which was managed by male doctors and medical students, and the other was staffed by female midwives. And he discovered that women in the clinic, staffed by the doctors and medical students, died at a rate nearly 5 times higher than the woman in the midwife's clinic. A pathologist had fallen ill and died. It seems that he had pricked his finger while doing an autopsy on someone who had died from childbed fever, but still it didn't answer the original question, why more women were dying from childbed fever in the doctor's clinic than in the midwife's clinic. And the big difference between the doctor's ward and the midwife's ward is that the doctors were performing autopsies, but the midwives weren't. So Semmelweis hypothesized that there were cadaverous particles and that the students were getting on their hands from the cadavers they dissected, and when they delivered these babies, these particles would get inside the woman who would develop the disease and die. So henceforth he ordered to his medical staff that they need to clean their hands, they need to clean their instruments, not just with soap and water, but with chlorine solution. And there was a technique of how it has to be done. In those days, this was the best disinfectant. So you can see in the picture the steps of hand washing. So first you need to rinse, then you use soap, then you use palms to palm, then the fingers are interlaced, and then you have back to the hands, then base of the thumbs, then the fingernails, which has to be cleared, and then lastly, this is how you go to the wrist joint. So all the steps have to be done, including all of you have to practice this, and at least for 30 seconds to 3 to 4 minutes, you need to do this. Let's go through each and every topic as we have discussed in the overview. The first one is septic abortion. Well, I recollect my days when I was a postgraduate 34 years back, where we used to get patients with pus in the uterus or some wooden fig or a twig inside, which was introduced by a quack, and they used to come with fever and sepsis and a foul smelling discharge from the vagina. And in those days, we used to have patients coming to us in a very bad situation where they used to be in sepsis, and in those days we used to have a very high mortality of such cases. Well, abortion laws have changed since then. As you are aware, it has been passed in 1971, and now various changes have taken place. Amendments have been taken place in 2021, and there is legislation of abortions. But still there are women in rural areas, in tribal and hilly region, they are not getting the benefit of a doctor, and they unfortunately go to a quack. There is lack of education still remaining in our society, and there are social taboos. This is how a picture illustration is there of a baby with pus around it and sepsis, and you can see that it has a bleeding per vaginum going out with pus fluid and a foul smelling discharge, and there is hot vagina. Well, so it usually results with the use of non-sterile techniques. The patient comes with fever, with chills, and as I mentioned, a foul smelling discharge, and the infection then further spreads into the tubes, to the ovaries, and to the peritoneum. There is localized guarding, tenderness, and then it becomes generalized further, and it can deteriorate. And there you find that it enters into the bloodstream, and then the patient goes in septicemia. So you need to understand that such patients, when they come, they have to be immediately started on antibiotics, preferably broad spectrum antibiotics. And you have some part of deliveries, some section of deliveries where still there are home deliveries, because there is lack of accessibility of our mothers, especially in northeastern region of India, or in tribal region, or in Adivasis, where the doctor to patient ratio is not good, and you have patients still delivering by dais, by ayas, and they crush the umbilical cord with a stone or a knife or a blade which is unsterile, and still these patients can land up with issues of sepsis. Septic abortion, septic delivery is a worst scenario which you come across, wherein in the institute it's very less common. But if you have a patient with peritonitis, abscess loculi are formed into the pouch or a Douglas, in the paracolic gutters, below the diaphragm, below the spleen, and then you have a whole features of sepsis, full blown, and that can lead to endotoxic shock. This is the picture where it tells you the pelvic thrombophlebitis and how the infection and the spread occurs through the veins, and then it worsens. It can be seen as a mild endometritis, later on thrombophlebitis, and often around the 14th or 15th day of the puerperum, you have such patients coming. This is because of the stagnation of the blood in the vessels, because it is slowed, the blood flow is slowed, and there are clots being formed. And then there is a severe necrosis in the veins, and that further results in pelvic abscess. In severe instances, it can become systemic and result in a lung, kidney, or heart valve abscess. Well, I would like to mention here one case report which has been published in an international journal. It was in 2016, where myself and the other co-authors went through this patient. It was a case of puerperal sepsis. She was a multiparous, unregistered, unimmunized, from a low socioeconomic status, and she was of poor nutrition. She delivered on a roadside footpath by an untrained birth attendant. There was no antibiotic cover. By the time she sought medical care on 11th day post-delivery, she had developed full-blown puerperal sepsis with pelvic abscess. An early surgical intervention with aggressive therapy was life-saving for this patient, and that's how we could save. However, such cases reports remind us that we still have a long way to go to ensure 100% institutional delivery rate. Now we go to the next topic of HIV, hepatitis B, C, and syphilis. The global pooled prevalence in pregnant women starts from 2.9%, 4.8%, 1%, and 0.8% respectively, and it varies considerably as per the geographic region and the country income levels. Now, the best part is that the prevalence of all these diseases among the pregnant women is now dropping, and it is coming down. It's because of a good educational awareness, universal screening, a better accessibility of treatment modalities. Now we are using disposable needles, and there is a regulation of blood transfusion, and increase usage of barrier contraceptions. What I used to see in 90s and 2000, now in 2020 decade, we find less and less patients of pregnant women with these infections. You can see here the prevalence of HIV amongst pregnant women, the national and the regional. You have the southern, the western region, and the northeastern region, varying from the year 2002 to 2021. And you find that the HIV prevalence is reducing. However, it's little higher side in the northeastern region as compared to the west and south. And that is a very good way because of the awareness of education, accessibility of the healthcare professional to, and the awareness helps these patients to come. Because of tribal, because of hilly region, the prevalence still is little higher. That is because of lack of accessibility of healthcare professionals. This is also showing the prevalence of HIV, the syphilis, and the HCV virus ranging from 2009 to 2018. And you can see that the green line shows the syphilis, which was the highest at the peak of 2012. But if you compare that with the HIV and HCV, it is going down. And that is a very good sign where you find the prevalence of all these diseases coming down. Surgical site infection is a very big chunk of infections in obstetric and gynecology. Well, it is defined as a surgical site infection within 30 days of an operative procedure. So it could be a small episiotomy, a DNC performed, or a cesarean section, or a perineal tear repair, or a puerperal which has been operated, or an MTP, or a surgical procedure where there is a involvement, where the skin and subcut are cut open. There is a deep incision which is there, and it involves the fascia and muscle. So there, if the infection occurs within the 30 days, it's because of the emergence of antimicrobial resistant pathogens. And this is a very important day-to-day issue which we come across during our management of the patients. However, how much efforts we take in reducing the surgical site infections, we still have patients coming up with wound gapes. You can see the picture here. This patient on the left-hand side is a post-operative case which has come to the family planning OPD. The sutures are removed and you find that still there is a pus and infection and it is a total gape. Such patients need to be readmitted. On the right-hand side upper picture, you find that there is a certain amount of infection which is there, and there is a swelling which you can see on the upper and the lower flap because it is induration is there below, and there could be infection. And once you open this alternate sutures, you will find that there is some amount of opening and there is a tunneling which goes, and that needs to be tackled, and where we need to readmit. So remember, when you have patients which you have operated in a gynecological surgery or an LSES, please do not send these patients home, admit them and see that antibiotics, a proper hygienic care and proper cleaning of the wound and daily dressing, daily 2 times dressing and good care to the mother is given. On the images which are there, you can find that there is an episiotomy which has gaped, and that's how you have a big hematoma there down which has been cleared, and this can occur in a post-operative episiotomy suturing or a perineal tear, and you need to be very careful. And this suturing, then resuturing has to be done properly with proper technique also has to be done. It's very important that when you are closing the skin suture on the right hand side, do not be very tight, because if you tight, it causes a local necrosis, and that's how the healing process is affected. So your throw of surgical knot should be not so tight that the knots are just approximating the wound, approximating layer by layer, so that there is no infection occurring. And clean scrub properly post-operatively with betadine, with proper gloves which are there and aseptic precautions. Let's revisit some ancient healing methods. Well, as I mentioned, Sushruta has been called as the father of surgery and the father of modern ancient medicine. He has derived some two words, Vrana Shodhan and Vrana Ropan, that is certain procedures and drugs which has been used to obtain a very clean wound. There are some medicinal plants also. We have commonly the Ficus bengalensis, which is the banyan tree. The leaves of these banyan trees are also put on the wound, and it is very having good property of wound healing. These are some of the plants which have been mentioned. They are in the names are there, and they are having good properties of anti-healing, and they are also used for wound healing. Well, how can we forget Hippocrates? We cannot forget him. It's 460 to 377 BC. He is also a father of medicine, and he has used vinegar to irrigate the open wounds and wrap the dressing around the wounds to prevent further injury. He has also washed the ulcers with wine, and after having softened them with the oil, he has dressed them with fig leaves. So this is what is also mentioned, and a very important points being given by the Greek physician and surgeon. Well, the professor of surgery in London, the 19th century, Dr. Joseph Lister, he recognized that antisepsis could prevent infection. Lister placed carbolic acid into open fractures to sterilize the wound and prevent sepsis. Well, this is Alexander Fleming in 1928. The use of antibiotics ushered a new era in wound care. He was a Scottish physician and he discovered penicillin. Well, penicillin was used clinically in 1940. However, the use of antibiotics did not end wound infection as resistant bacteria and new surgical interventions have risen. So this was a primary method for wound management and in its prevention. And hence later on from 1928 onwards, the use of antibiotics, the proper wound cleaning, the surgical drainage and excision of damaged tissue are now the primary methods of wound management till date. Now, this is the spectrum of antibiotics, and you can find that the various antibiotics are used for the gram-positive, gram-negative, anaerobes, and the different antibiotics. So we have penicillin to begin with, ampicillin, amoxicillin, sulbactam. Then we have piperacillin, carbapenems, then cephalosporins, first generation, second, third, fourth, fifth, and then we have aminoglycosides which take care of the gram-negative bacteria, metronidazole, and of course we have the Cipro, Levo, and cefadexidine. So all these drugs and all these antibiotics are used for this gram-positive anaerobes and gram-negative bacteria. So it's very important that why you get an increased rate of surgical site infection. It's because of the policy which you are following, the procedures which you are doing, and if you have the people and you have the place which we have, but there are no standard antibiotic policy being followed, there is no surgical safety checklist, there are no standards SOP guidelines, and then we have the issue about the residents, the increased OT traffic. The OT staffs are overburdened. In Sion Hospital, we have patients lined up for cesarean section, and the whole OT is 24 hours working. There is a lack of proper fumigation and changing the cleaning of the operation theater. Then there is one entry, one exit OT, no proper biomedical waste management. the sink and in the OT is hand operated. So there are all various causes. Well, in addition to this, it's our also very important role to play to reduce the surgical site infections. I always tell my resident doctors and the colleagues which are there that we need to cut our fingernails every OT, every week. We need to have and a proper scrubbing to be done for at least 3 to 5 minutes before any procedure, and to take care of tissue respect while doing surgery, say a cesarean section or a gynecological. Blood is an important or important medium. It's a very good culture of growth of bacteria. So you have to do bloodless surgery. You need to understand that good tissue respect and using your good surgical skills, patience, perseverance. I'm sure you will not have any wound infection, you will not have any gapes, you will not have patients coming with fever. So this is a very important thing, and there is no hurry. We are hurrying in hurry because there is a lot of overload in the labor OT. But yes, we need to do fast surgery.
Requesting everyone to please mute themselves.
Surgery is waiting, but at the same time, the quality of care and the quality of to see that there is a less surgical site infection has to be maintained. Well, these are all other causes like overcrowding. You have admission discharge policy, a standard OT sterilization procedure is not maintained. The OT is not properly cleaned, as I mentioned earlier, and it is not sterilized. Between two patients, you don't give that much time for it to undergo a proper sterilization. Well, the antibiotics you need to give, well, they recommend that just when the OT operation is started, you need to give one shot of antibiotic, or intraoperatively that is missed out. And there are so many other things. While preparing also the patient during anesthesia, the care and the safety and also proper antiseptic precautions have to be maintained. And well, the procedure has to be done, completed properly, and the patient is shifted, and all these situations shifted to the ward, we need to have a proper protocol being followed. Now, the most important what we would like to talk today is about puerperal sepsis. And this topic of infection and obstetric and gynae could not be complete without giving due stress on this point of puerperal sepsis. So we all know what is puerperal sepsis, but just to mention here, it is an infection of the genital tract, and that occurs anytime from the time of rupture of membranes or labor to begin, and then it goes up till 42 days postpartum, is known as puerperal sepsis. You can see the diagram, the picture there, and you can find that there is an inflammation, infection of the endometrial cavity, and it can go further into the myometrium, and the patient then comes with fever, with pain, tenderness, there is hot vagina, and if it is much more severe, then you will have a foul smelling, whitish, yellowish type of a discharge. And then later on, there is abnormal vaginal discharge. There is involution of the uterus. I still remember one patient who has been there in the ward with, not having proper involution of the uterus and remaining for more than 1.5 months in my ward. So we have to be very careful. Well, she went home properly. We had to give a lot of antibiotics over a period of time. So it's very important that you need to find the focus of infection, and it's very important that a proper history is taken. We are a tertiary center, and we get patients not only from our own hospital which are registered, but we get from the 22 maternity hospitals and peripheral hospitals which are their nursing homes, where they transfer us cases post-operatively, day 3, day 4, or a normal delivery or a forceps been applied, and then you have patients coming up with lot of infections. It could be urinary tract infection, infection in the breast like mastitis, a breast abscess, or the gape of the LSE has been done. And there could be any other surgical cause like appendicitis, pharyngitis, or gastroenteritis. So you have to understand that the commonest pathogen of sepsis is the gram positive, and that is the Streptococcus pyogenes. Then we have E. coli. Then we have other organisms which are there, and MRSA. It forms a very major chunk of causing infection and sepsis. And GAS is also increasingly causing invasive infections. It's a worst scenario, and they can also cause directly a maternal death from this infection. And we have such cases coming also. So what are the red flags of sepsis? This is very important. So any patient who is delivered or who is aborted and they have a fever of more than 38 degrees and it is at least for 2 to 3 days, there is sustained tachycardia which can go anything above 90 beats per minute, and there is breathlessness over a period of time, and there is abdominal pain, there is generalized, then later on peritonitis, inflammation going into the upper abdomen. So there is, tenderness, guarding, there could be rigidity. You need to have a surgical reference, get an ultrasound done. Well, we'll come to that, but it's very important that there might be a uterine or a renal angle pain and tenderness. So what are you supposed to do apart from the routine investigation of hemoglobin, complete blood count, and all the proper peripheral smear which you do? You have to find out whether there is leukocytosis, the platelet count is affected, and blood cultures, if the patient has got a hot vagina and there is suspected puerperal sepsis, a vaginal swab or an abdominal wound swab. I still remember when the patients are having chorioamnionitis, and when you deliver the baby out, when you touch the placenta is very hot and you need to take a placental swab or from the abdominal cavity. So this is very important that you have to send the culture sensitivity antibiotic test also. And serum lactate is also to be measured within 6 hours of the suspicion of severe sepsis. And of course, if you are having an ultrasound, which we have, you can utilize it and find out whether there are any pus pockets into the pouch or Douglas, or there are pus pockets which are present, loculi which are there within the uterine cavity, or there is a clot, or there is a in the endometrial cavity. So a CT scan or an ultrasound scan is also very helpful, because we need to find the local source of infection and to attack on that and then help it to resolve. So blood culture plays a very important role, and well, a CT has also a very important role depending upon what facilities available. Well, of course, you have the blood count, the urea, the C-reactive protein levels, which are very high. Some of them recommend, if there is any woman who has got tonsillitis, pharyngitis, to take a throat swab. And then if the MRSA status of the woman is unknown, pre-moisture nose swab may also be taken for the rapid MRSA screening wherever the test is available. So most importantly, the management is that you need to admit such cases, do not send them home, take no chance with such a woman, especially with pregnancy. Find out what is the focus of infection on your investigation, and you need to do a uterine evacuation, but do not do any early instrumentation of the uterus. Even if the ultrasound picture shows anything in the first 12 hours, 8 to 12 hours, give her a good antibiotic coverage. You can give her uterotonics so that it can come out medically, curettage if possible, or drain a breast abscess or any pelvic abscess, or open the wound if there is a abdominal wound so that the tunnel can be opened, remove out the pus, because that is going to relieve and suddenly get down the puerperal sepsis. And put her on broad spectrum antibiotics, put on ringalactate, give her IV fluids, explain to the relatives, the consent is taken if any procedure has to be done. So IV antibiotics need to be given for at least 4 to 7 days, 3 to 7 days. You might need to catheterize the patient because the urine output is very important, and all the parameters have to be considered so that she doesn't go in full blown sepsis or further involvement of other organs like lungs or say kidneys, and further involvement of spreading the pus into our bloodstream and causing a full-blown sepsis. So these are all the pictures you have to understand. Here you see the breast picture where there is you need to take an incision and cut open and remove that abscess, intramammary abscess, where there could be a para-areolar incision for the drainage, which can do. The loculi need to be broken. And if you have the infection into the uterine cavity, or there is a pus into the pouch or a Douglas, or you need to drain out the infection or pus into the paracolligators, a simple speculum and lifting up the posterior lip of the cervix upwards with a valsellum and giving a colpotomy an opening with an artery will drain out that pelvic abscess pus and a good head low. I've seen this case in MICU when I was a lecturer, and we used to go there and see the patient, and for 30 days we monitored her, and we also had to put a Malicot's drain. You can put a Malicot's drain also inside so that it constantly pours off. So we avoided an exploratory laparotomy in such cases when the patient condition is not so good for surgery to be taken. Well, piperacillin, gram-negative organism, tazobactam or carbapenem plus clindamycin provides a very good range of IV antibiotics. And you have to understand that clindamycin is a very important drug if required. And if the woman is highly likely to be MRSA positive, then a glycopeptide such as vancomycin or teicoplanin may also be added. Now, there are certain recent advances which I would like to share with you, and these are quite opening up. There is something like gene therapy. Genes can be delivered into the wounds by different methods. Well, there are viral vectors which are biological. There are physical micro injections and chemical cationic liposomes, and these have been utilized for wound healing. Basically, they go in and they affect the cells and their environment by their products of expression. And this is the tissue engineered substitutes, and there are growth factors which are also used. So it will affect the inflammatory phase, the proliferative phase, and the remodeling phase of an infection. And when you have oxygenation and the gene therapy which we give, it helps in wound healing by oxidative burst, by the metabolic needs and the collagen formation and maturation. Currently used therapies for non-healing wound includes presently is suctioning drain, which we utilize. You can see at the upper picture there, you have a well orchestrated suction drainage, which has been instituted into the subcutaneous cavity, and that is to be done every 8 hourly. So any fluid or any because of the edema and the fluid, which is inflammatory fluid, it can be sucked out and it doesn't become a source of infection or a good medium, and bacteria do not multiply. And you have a negative pressure wound therapy also can be given, which you can see here, a proper placement being done. And then if there are chronic venous ulcers, in some cases, you have intermittent pneumatic compression. So the take home message, we have to face the new infectious threats boldly. We cannot go back. We have to face it. We have to face it daily. And we do not have to land up in any medical legal complications. So it's very important that all your advanced diagnostic facilities available in your center, whichever your place you're practicing, and a good protocol and treatment is maintained. There is a hospital infection committee which regulates every fortnight, and they collect the swabs from the operation theater, from the wards. Even they collect the swabs from the OT table, the OT ceiling light and the walls, and wherever you find that proper antibiotic has to be given for that particular bacteria. So that is a very important thing. A proper sterilization, autoclaving, and washing of your hands are very important. You have to understand that these are the basic necessities you have to follow when you are an obstetrician and a good surgeon, and that is going to help you to reduce your infection rate. So stringent preventive measures, implementation, and cutting edge technologies are very important to be used. Well, I would like to end my talk by a famous author, Hans Zenzer, where he has said that infectious disease is one of the few genuine adventures left in the world. And by Tyler Hess, kindness is the most infectious disease. Try to spread it. Be kind, be empathetic to the tissue, respect the tissue, do your surgeries bloodlessly, and do it safely, do it swiftly, do it relentlessly. See that you have a proper instrumentation and a good team which develops into not only operating the case, but also post-operative care is very important in such. So we need to understand that all these things are to be done properly. So I thank Dr. Anju Soni for inviting me today for this presentation on the wisdoms on the CCC series. And thank you so much. I'm signing off now from Mumbai. Have a great time and be safe. Take care. Thank you so much.
I think Niranjan, are you there? Dr.
Yeah,
Niranjan?
I'm there. I'm listening.
Uh,
Yes.
excellent talk as always, and a lot of, insights in the history of, you just gave the, detailed history of how, the instruments evolved, how the medicine evolved, and how careful we should be in the medical practice. So thank you so much, Niranjan. A very good talk. And you also told about the recent updates which are coming up in infection prevention. And we do talk about infection prevention. We do take, but in the private facilities, somehow we don't see that much of sepsis. It's mainly in the public facilities that you are dealing with. But private, we are more careful a little bit, maybe because the patient comes for the follow-up. So infection as a sepsis is not so common in the private facilities. It is more so in the public facility. So thank you so much. I gone back to the days of residency when we used to do a lot of colpotomies, and when there was a pus, especially in the post-abortal period or in the puerperal sepsis, and even after the cesarean section, sometimes with the puerperal sepsis. So that, really improved the condition, and always put a drain whenever you are operating for a, infected case. So thank you so much, Niranjan. If there are any questions, Kanchan, see that if there is any question in the chat box, or if Dr. Anju Soni wants to comment, you are welcome.
There's no question right now, ma'am. So I would request Anju Soni ma'am to give some comment.
It's been a good, it's been a terrific journey from past to future. Niranjan, thank you so much. This was our
topic very well covered, I must say.
It was
I
our
was just
thought
thinking
that
what he will speak on past, present, and future.
Yeah. So we thought of this topic, and you gave a full justice to the topic, and I think it was much be an eye opener for a lot of people. We all know that we do not give any, as Dr. Preeti said, that we give value to the anemia part, we give value to the hypertension, diabetes in pregnancy, even PPH, but we do not talk of infection per se, which is so very important, and that comes to be very important cause of maternal mortality in our country. So thank you for being there, and just give me a second. We wanted to, we just want to thank you as well as Dr. Geeta for your presence, and we'll be sharing your plaque to you on your mail on your mail ID.
Yes.
So thank you very much. And before ending, thank you, I would just have a gentle request from everyone. Is my screen visible?
No, ma'am, not it. Yes, it is.
Now
It
it's
is
visible.
appearing.
Visible now?
Yes, ma'am.
Yes.
Yeah. So a gentle request for me to just give one vote from West Zone. I have a gentle request from all of you. Please vote for me as VP Foxy. Thank you so much. And over to you for your thank you note.
Thank you so much, Anju ma'am. And now I hand over the mic to Dr. Subha Sethia ma'am.
Thanks, Kanchan. First of all, it was a great pleasure to attend this webinar and have a great academic feast. Both our speakers have motivated us a lot. And I think we will all strive hard to get our maternal mortality less than 70. And this needs not just the government motivation, but also motivation on our parts too. And of course, Dr. Niranjan, the way you delved into past, present, and future, it shows how we can be innovative, learning from the past and going to the future. Thank you, Dr. Niranjan, so much for your journey that you have taken us to. And deriving the inspiration from your journeys, I would like to tell you that next week also we are going to continue this journey. And here it is where we will be discussing what we doctors are supposed to do to prevent infection. And then in this series, we have none other than Dr. Anjana Khanna talking on OT and labor room protocols to prevent infection. And then we will have Dr. Seema Pandey speaking on surgical site infections. And to chair these sessions, we have none other than Dr. Archana Verma, past President Foxy, and Dr.
Past
Kiran
VP.
Pandey,
Past
who
VP.
is past Vice President Foxy, and Dr. Kiran Pandey, who is the chairperson for the violence.
No, Kiran Pandey, Dr. Kiran. Kiran Naik.
Dr. Kiran, okay. So, who is chairperson for the Violence Against Women Committee. And before I thank you all, my greatest thanks to Dr. Preeti, who I think talks so much about the topic, and that too in a very non-assuming manner. I think her knowledge is vast, her experience is vast, and I thank her. And last but not the least, thanks to Dr. Anju Soni, whose great vision. I don't know how she could come to this topic of confusion, clarity, and consensus. And we had enjoyed the whole conference with this topic, and now the webinar series where we are trying to reach people who have not been able to attend the conference and still reap the benefits of all the topics of the conference. So thank you very much, everyone. And I hope you will join us in the next webisode too. So thank you so much.
Thank you, everyone. And let's meet next week again.
Thank you. Thank you so much, ma'am.
Bye. 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 Bye.